the world can be a dumpster fire sometimes.
It's not relaxing at all.
Don't come at me.
I swear to God. I'm doing my best.
Internalized shame can lead us to having deep-seated core beliefs about ourselves, and those are the hardest to change. Essentially, we're not taught these skills ever.
The media likes to paint this picture that youth in particular are fast-tracked into medical transitioning.
Regret and detransition do happen.
I still feel like a youth.
100%.
Yeah.
What's going on, everybody? Welcome back to the Queer Collective podcast. I'm your host, Carbon.
I'm Emily.
And I'm June.
And welcome to the show. And this episode is sponsored by Vizzy Hard Seltzer, but more on that later.
From historic pathologizing to over-politicization, what role does psychiatry play in the lives of the 2S LGBTQIA plus community? In this episode, we're talking about LGBTQ plus mental health. We'll offer practical advice to many of our listeners' comments, and we'll be diving into the intersection of mental health and medical transitions. We'll explore the politicization of trans healthcare, navigating readiness for transition, and addressing regret and detransition. Stay with us.
And today we have with us June Lam, who uses he, him pronouns, is a psychiatrist in the CAMH Emergency Department and the Gender Identity Clinic, which supports transgender and gender diverse patients interested in accessing medical transition. He's also a health services researcher with a research focus on access to mental health care for transgender and gender diverse people. His academic and clinical focus is on care for LGBTQ2S plus communities. He is the current co-lead of the ECHO Trans and Gender Diverse Healthcare Program. June, welcome to the show.
Thank you.
Okay, so the first place that we want to start today is queer mental health in general. I'm wondering if you can share what inspired you to focus your practice on the queer community.
Being part of the community, I've always been interested in supporting my own community. But to be honest, going through residency in psychiatry, I was kind of ambivalent about whether I wanted to actually focus on queer mental health as part of my practice or as a major part of my practice. But then near the end of my residency, one of my friends who I had watched him transition medically and socially, near the end of my residency, he unfortunately died by suicide. And that was when I kind of really realized that there's still a lot of work that needs to be done in terms of addressing health inequities that our communities face, and in particular that there are certain subgroups or communities within our larger community that has kind of been left behind. After that happened, I really felt like it was important to dedicate a large part of my career to this work. So.
Thank you so much for sharing that. I'm really sorry to hear about your friend. Like you mentioned, the queer community faces worse mental health outcomes than our straight counterparts. And I'm wondering if you can share what's causing this disparity.
From my perspective, it's not really our identities that lead to disproportionate mental health challenges, but more around this idea of minority stress. So the minority stress theory, you may already know, is this idea that there's a lot of discrimination in society towards minoritized groups. In this case, if we're talking about queer and trans folks, that can lead to not only like verbal, physical, sexual trauma, but also social determinants of health issues like housing instability, financial instability, employment discrimination. So all of that leads to increased stress for folks within our communities. And because of cortisol, stress hormones and other physiological changes, that can lead to increased rates of physical health issues and mental health challenges. And some of the sort of most prominent mental health challenges would be depression, anxiety, but also trauma-related like PTSD. Lots of folks within our communities also end up using substances as a way to cope. That can lead to addictions problems as well.
You mentioned specifically like minorities.
Minority stress.
Yes, minority
stress. Is that like the number one cause for the queer community having sort of overall poor mental health conditions?
Yes, I think so. I would frame it, I would say it this way. I think people in general have many causes for mental health challenges. So there's kind of a baseline rate of mental health issues or mental illness that the general population would have. I would say the excess or, increased or extra, rates of mental health issues that queer folks experience, that I largely attribute to minority stress, facing discrimination in this world. It can also include like family rejection, family stress, interpersonal conflict related to that. And then the other thing I wanted to add that I forgot to mention was another source of sort of extra distress or mental health challenges that our communities face is for trans and gender diverse folks who experience gender incongruence or gender dysphoria. Aspects of their body or their physical appearance don't match their internalized gender or their experienced gender. That's another source of distress for our communities as well.
It's the society that we live in, I guess, not necessarily us. I'm wondering, with such major systemic and societal cultural problems impacting our community, do you believe that individual acts like therapy and medication can be the solution when it's on such a systemic level?
In psychiatry and psychology, mental health, we talk a lot about dialectics, both and, like two things can be true at the same time, like yin and yang. And so that's kind of how I would respond to that question. I think that both are necessary, by which I mean both systemic structural changes, advocacy for greater access to housing, financial stability, addressing discrimination broadly. Change takes time, unfortunately. So in the meantime, a lot of folks in our community are struggling. And so we know we have evidence to suggest that therapy, medications, and other mental health treatments are evidence-based for the individual. So encourage folks who are struggling with their mental health to look into these individual treatments and just know that, again, both and, meaning you didn't cause your mental health challenges or mental illness. And at the same time, there are things that you can do to improve your mental health. And we really want you to try to think about those options.
I think dealing with the systems at bay can be very overwhelming and stressful for a lot of people. I know several of our listener comments were wondering how to just cope with the state of the world and that general state of anxiety. And I'm wondering what your best advice for that would be.
One of the first steps for me personally is to acknowledge it, to validate yourself that the world can be a dumpster fire sometimes. And especially with some of the, political things that are happening, not only in other countries, but also in ours. And then if I could offer some possible suggestions, I think one would be boundary setting, limiting kind of the doom scrolling that we all can do in terms of reading the news, in terms of being on social media. I think keeping up to date is really helpful. I try to keep updated in terms of the news as well. But I think maybe set some time limits, maybe, certain times of the day, or at least 2-hour breaks, or, whatever works for you. So you're not doom scrolling all the time. I think sometimes part of it is that we're so connected now in terms of knowing things that happen across the world, which is great because that's important for us to know. But that can make us feel helpless and a bit hopeless, especially if it's far away and it doesn't feel like we can make a huge impact. There are things that you can do. There's this phrase that I think about, think global, act local. So this idea that, you can have a global perspective, but there are things you can do close to home, whether that's helping communities that are affected, or advocating through protests or other activities or events. Really also find places of queer joy. Finding the opposite of doom and gloom is queer joy and queer excellence. And I think that part of that is, connecting to community.
I think it's also radical to express yourself in your full queerness when people are trying to regulate and control that. It's a form of protest.
It's a form of resistance. Yes, 1,000%. Yes, exactly. Sometimes it can feel like the world just wants you to be quiet or to be sad and to be doom and gloom.
Crush your spirit.
Yeah. And so, yes, so finding joy wherever that is, in community, in books or TV shows or movies, and finding role models, people you can look up to that you consider that give you queer joy, that show you what queer excellence looks like, can be really inspiring. And like you said, challenge the haters.
Yeah. I love so much of what you said. I think it really speaks to, you mentioned high cortisol levels in the beginning, and I think all of your advice kind of speaks to that and trying to cure the stress, because I think the environment that we set up, we being this bigger term, the society that we live in, this very work-focused capitalist environment surrounded by screens, the thing you mentioned about limiting your screen time. I was starting to notice, just having to do social media for a job, the more that I'm consuming it, I think A lot of people use TikTok and Instagram as a way to like de-stress, but then you start going on these videos, they're going like 100 miles a minute. One second you're seeing something like really triggering and traumatizing about something that's happening in another part of the world. And then the next minute it's a funny video about a dog, and then you're seeing like an outfit inspo, and it's just like you're going in so many different directions that if you are already like a high stress individual, you leave that experience of like doom scrolling feeling a lot worse if you actually like really tap in with your body.
It's not relaxing at all. And,
No.
you know, I think TikTok looks very innocent to a lot of people because it's like the average person creating content. But this average person, at least if they're, you know, doing it well, has strategies that they implement to capture your attention. So
in 3 seconds.
In 3 seconds or less.
In our field, we kind of talk about how, especially TikTok, is meant to sort of hit your dopamine, right? It's meant to release like a bunch of, you know, the dopamine in your brain. It's made for that, but our bodies and our brains are not evolved to have that frequency or intensity of dopamine or other neurochemicals in our brain released that frequently. And I really like what you said about your emotions going all over the place, like watching a video about something really challenging or difficult or tragic or sad, and then followed by something really funny or silly or you know, or makes you angry. And you know, in our field we have so much psychiatry talk and psychology talk, but you may have heard of a term called emotion regulation, and you know, we talk a lot about that. TikTok and other social media, it kind of facilitates emotion dysregulation because you're going from one extreme to another extreme. And like you said, I don't think it lets you really relax. Intentional relaxation, I don't think it really allows for that.
Well, if we think about like our physiological history as human beings, like meant to be in nature, certainly not meant to consume this much information in a matter of seconds. I think I read one stat, I probably get it wrong, but we consume more information in one day than someone 100 years ago probably consumed their entire life. And just keeping that in mind makes you realize that like a lot of what we're doing is unnatural, and of course is leading to these like high stress levels that are making you so deregulated. And I think focusing on that as like the cause of the problem and finding ways to change your daily life in order to have a more calm self would be smart.
Yes, and I think it's like a double-edged sword because especially for queer community, as you know, like it also has allowed us to connect in a way that's sort of more so than we ever have. You know, find each other, find community, especially for folks living in maybe more rural or remote areas. But I think it's a double-edged sword. I think if we can set some boundaries around it and know that it's sort of there's like nothing, everything in moderation, right? So I think that would be just better for all of us.
What are some of your tips on how to manage severe anxiety and ruminating on things that are sort of going wrong in the world?
Maybe finding other ways to connect to folks or advocate with your community or to feel like you're taking action towards things that you care about. Not everybody's able to access, you know, counseling or therapy. But we can talk about some ways to try to do that. But if you're able to, I do think that having somebody professional who is dedicated to teach you some skills from, you know, mindfulness, coping skills, other types of more formal therapies. I think that can also be a way to teach ourselves how to regulate our emotions, set boundaries, assert our needs and our values. And I think all of those are ways that you can manage anxiety along with, we call it techniques, but like distraction or self-soothing, which is, distraction is really like doing things that you enjoy. Self-soothing is the same. You know, taking a bubble bath or taking a walk outside, things that can help soothe and regulate your nervous system when you're feeling dysregulated or distressed.
Yeah, I'll say I'm an individual who definitely struggles with severe anxiety and like these ruminating thoughts. And I have since I was like very little, but the ways that I've been able to get out of it is like you said, like changing your environment, like going outside, going on a walk, like even if you're feeling really, really horrible, changing your environment, reaching out to a friend and having a conversation with someone to like ground yourself and rationalize things, I think can really help. For me, I started doing yoga when I would start to feel really stressed and like finding different mindfulness activities. I think when you're really far into it though, it can be so challenging to just get yourself up to even start to do that, to start to change your environment. And not sponsored by them at all, but what helped me do this was this app called Finch, and we're both on it, and it helps. But you take care of this like little bird and you help it grow, and like it's kind of like having a pet for people who like can't have a pet right now, you know what I mean? But you attach like goals to it, and it honestly sometimes it's what helps me get out of bed, and it's like I think it can help other people too. I found it really nice.
Maybe try checking out the app Finch.
Yeah,
FINCH, not sponsored, but you're welcome.
I think apps are a great idea. I think part of the only issue I have with apps is there's a lot of variability, and you know, I'm a researcher, so I'm like very evidence based. Many of them are evidence based, but I would just maybe look into it, make sure that you know you feel comfortable with sort of how they developed it and sort of their kind of philosophy. But I think apps can offer structure, support, and many people have benefited from apps for their mental health. So
You're talking about stress, anxiety, and boundaries in particular. And right now, as we're recording this, the holidays are coming up. And for a lot of people, and in particular queer folks, seeing their family can be a bit of a touchy subject. It can be sometimes triggering or reliving trauma. Do you have any advice for folks that are potentially going to see their families? They want to do that, but also it's hard.
yes, this is where the word of the day, boundaries, comes up again.
Yeah.
as you alluded to, as you said. Because that is sort of a major theme sort of on this topic for me anyway. But I would say that boundaries is not a one-size-fits-all. I actually gave this talk just earlier today about racialized identities in trans healthcare. And one of the things that I like to talk about is that coming out is like a white concept. This idea that, this concept that like coming out as conceptualized as like the end goal is that you are out to every single person in your life and they all have to like celebrate and then march in the pride parade. I think that is not safe for everybody, but also not necessarily desirable for everybody. And so that's kind of related to boundaries are not a one size fits all, you know? So I think that for me, what I might recommend, first of all, is to kind of reflect on your values, right? So like you said, some people, spending time with family is important to them. And perhaps for some, it's less or even just purely harmful. But sort of standing up for yourself is a value that's important. Sometimes those values can be in tension. And in that case, you know, that's when I think being creative or flexible around how you set your boundaries can be helpful. Depending on your situation, it might mean going to the dinner on one day, but not for, you know, sometimes people spend like a whole week or, you know, a couple of weeks, right? Or, you know, some not staying under the same roof as your family, but maybe if you are able to get a place like close by, but so you don't have to, you can go home to a place that feels like your own, that you don't feel like you're in the same roof as the people who maybe you feel are not fully accepting of you. And if you're able to, beforehand, you could try to set some boundaries with those family members, right? Here's what we're not going to talk about. Here's what we can talk about. I'm bringing this person or I'm not bringing this person. And, you know, there's no perfect solution, but I think just thinking about your values, what's important to you, and then maybe coming up with a plan beforehand. And if it is too hard, I think it's okay to also like not do the holidays with a bunch of family, or maybe do smaller events, or maybe say, you know what, I won't join for the holidays because it's a hard time for me. You know, I can offer to meet after or just before. Hopefully that helps, but I think that I support you in acting consistent with whatever your values are.
Yeah, I definitely agree. For the first year, I implemented boundaries around Christmas, and I was like, wow, it feels so much better to not stay for a whole week at my dad's house. You do these things. You do these things because they're like a tradition. Like, I've been doing it since I was little, and like, I feel so bad to say I'm not doing it, but it's like, you're an adult. You can be an adult. You can make your own choices. Like, that's okay. And like, they can respect that. I don't know. In turn, I've also seen my dad start to set his own boundaries with his own mom now. now. You know what I mean? So I'm like,
That's
everyone,
great.
it's a passed down effect. Everyone's learning it in my family now.
I love that. Can I just also add that maybe to have kind of like a crisis plan for the holidays, you know? For some people, this is not everybody's situation, but for some people, the holidays are actually really, really hard and really, really perhaps triggering. It might be helpful to have kind of a safety plan or a crisis plan of like coping ahead. What can I do if I am really distressed? You know, who can I contact? Having scheduled activities with your chosen family that can be rejuvenating as opposed to, you know, exhausting. And then also like crisis lines, you know, community crisis lines, community organizations you can reach out to so you don't feel alone if you need support. And of course, you know, if you need to, you can go to the hospital emergency, but hopefully it doesn't get to that point. But I think that it's just, that might be another thing that I would recommend.
For the two of us, we've implemented like, okay, we're going to do something fun with either each other or friends, etc., after the family stuff is done to kind of like rejuvenate. Yeah.
It's conflicting emotions. It's like there are people who you love very much, you're very grateful to them, but it's hard to feel like you can't show up as your full authentic self with somebody. And it's kind of like wearing a mask for a period of time, and it can be really draining.
It's actually the hardest to deal with when you have mixed emotions.
Yeah.
If somebody just gives you pure unconditional love, or you know, they make you just purely happy, that's easy to deal with.
Yeah.
And if somebody's like a pure villain in your brain and they are just the worst, you know what to do because you can just cut them out of your life. But it's for people who we have mixed feelings with, where, you know, they don't see us fully perhaps, or they are trying, but they still misgender us, or they still, you know, they aren't able to be fully supportive in the way that we need and want them to be, but we still love them and we still want to stay connected. That is actually the hardest for us to navigate.
And I will say I'm glad that you brought up the point about coming out being a white concept, because I think you get people coming up to you a lot, kind of speaking about that as well. And I think lots of our friends have echoed that experience. We've had Moody coming on to share like the queer Palestinian experience, and he very much echoed exactly what you said, where it was like, well, coming out just like isn't even a thought in my mind, but my family loves and accepts me and I love them, you know, and it's just like something that is unspoken. But I think that is an important thing for people to remember. It's like whatever is your journey is totally okay. You don't have to follow what Western media is telling you.
So speaking of family, what actionable steps can loved ones take to support queer folks facing isolation or even potentially suicidal thoughts?
Really to take the lead of the person, because I think that queer folks, especially, you know, racialized queer folks and trans folks, oftentimes have had a lot of their agency taken away. You know, other folks have chosen for them in terms of what is right or what is correct or good. So I really encourage folks to challenge that and to really take the lead of the person themselves. So maybe asking what would be helpful. And you can offer suggestions. So if I'm imagining like my aunt who like is supportive, you know, and my parents are less supportive, for example. Maybe if I was the aunt, you know, or uncle, then I might say, I'm here for you. That's number one. And then what would be helpful? And if you want, you can offer some suggestions like, do you want me to correct them every time they misgender you? Or if they, you know, talk about, ask you to find a girlfriend, what do you want me to do? You know, do you want me to say something? But again, sometimes people actually don't want to cause you know, an interpersonal conflict over, you know, the holiday dinner. So again, taking the lead of the person. And then in terms of like suicidality, well, it might be helpful to have some, again, resources, but again, talking it through with the individual themselves. I really encourage crisis lines, community-based services that are depathologizing, that, you know, that are run by queer people and trans people, like the Trans Lifeline or the LGBT Youth Line. I really discourage people from calling 911 on queer and trans people because, again, folks have had a lot of their agency taken away, and you know, and calling 911, even if it's well-intentioned, that can feel re-traumatizing and, again, taking folks' agency away. So having sort of some resources, offering to be there, offering to advocate in the way that they want, I think those are some things that family members can think about.
What strategies and therapeutic approaches do you find are the most effective in helping patients unpack deeply rooted shame and internalize homophobia/transphobia?
Only the easy questions here on the Queer Collective
You're
podcast.
doing well, though. You got good answers. Good answers
These-
to hard questions.
These are hard questions, but I think these are really important questions. So I'm grateful for the opportunity. It's just...
You're just sweating a little.
Yeah, just sweating a little bit. The caveat being, I'm just one person, there's no right answer here. But that being said, here are some of my thoughts about that. Internalized shame, I think that the first thing, taking a step back, is to really acknowledge, again, that comes from society. Like the locus of internalized shame for our community is not us. It's not the identity. It's the society's messaging. We've had queerphobic messaging our entire lives. And so from the media, from family, from people we've grown up with, we should not be surprised that we have internalized some of that queerphobia, transphobia. I think this is something that I do encourage folks to get maybe some support through a counselor or a therapist if they're able to, because I think internalized shame is a tricky thing to manage, because when it's deep-rooted, it affects the way we think about ourselves. In cognitive behavioral therapy, or CBT, there is a phrase called core beliefs. And sometimes internalized shame can lead us to having deep-seated core beliefs about ourselves, and those are the hardest to change. It might be something to get some professional support around, although there are other things, that you can do to sort of deliberately consume media with more positive messaging. There's a lot of books, there's a lot of TV shows, especially written by queer, trans folks ourselves. I think I like a lot of TV shows like, Pose or Sort of. I'm a
Great ones.
Right? Thank you. I'm a big TV watcher, so that's from my perspective. But I think that can help when you're not surrounding yourself with negative messaging all the time.
Yeah.
So the one thing we have not touched on as much is actual therapy and what that might look like. So at our at the Gender Identity Clinic at CAMH, where I work, we have two therapy skills groups. One based on cognitive behavioral therapy, CBT, and one based on dialectical behavioral therapy. They're adapted to address minority stress. These are some skills that can help you address that. So if you're not able to, or you don't want to do official therapy skills groups, there are some workbooks that are pretty cheap or low cost. DBT skills workbooks, CBT skills workbooks, especially if they are adapted for queer and trans communities. Those can teach or share some skills that working towards challenging internalized shame.
Can you dive a little deeper into the difference between the two therapies?
Sure. Oh, here we go. It's a test. It's like a psychiatry test. So cognitive behavioral therapy, or CBT, it's based on the idea that your emotions are linked to your behaviors and your thoughts, and all of that is linked to physiological reactions from your body. So if you struggle with depression, you may feel kind of clinically sad a lot of the time. And behavior-wise, that might lead you to not getting out of bed, not being able to go out even. In terms of your thoughts, it might be, I feel so alone, nobody cares about me. And then that might lead to physiological body reactions like feeling really tired. So the idea is that if you can shift one of those four corners, you can shift the other. Usually we're talking about shifting your body reactions or your physiological reactions, your thoughts, or your behavior. So if depression makes you want to stay home, then you can challenge that by deliberately going outside, what we call behavioral activation. It actually is kind of what the app that you were talking about is partly doing, is sort of giving you some structure and encouragement to encourage you to get out of the house, for example. From a thought perspective, that is kind of challenging the what we call cognitive distortions, or kind of distorted ways of thinking that depression or anxiety kind of leads you to having. CBT therapists teach you how to write a thought record. Like, what is the evidence for this statement? What is the evidence against this statement? How do we, based on this evidence, how do I kind of reappraise the thought? And then what is a more nuanced or appropriate or accurate thought? And then for your physiological reactions, your body reactions, if you are struggling with anxiety, sometimes that can lead to like your heart palpitating or feeling dizzy. And so an example of what you can do to address that is to do mindful breathing or boxed breathing. That can be a simple but effective way of physiologically toning down your system, your body. And that will feed back into your brain to then reduce your anxiety. So that's CBT. And CBT therapists, don't come at me.
I swear to God, I'm doing my best.
I'm doing my best. It's time limited. Come on now. And then dialectical behavioral therapy, DBT, takes CBT and adds quite a bit to it. DBT therapists are going to come at me and say, it's not CBT, but there are some principles of CBT and other stuff added. But there are 4 kind of cornerstones of DBT. Mindfulness, emotion regulation, interpersonal effectiveness, and distress tolerance. So mindfulness is really the cornerstone. Mindfulness is really developing a skill to be present in the moment, as I'm sure you and many of your listeners know. It's a harder skill to develop than one would think because, well, I don't have to really explain it, but especially in this world, right?
It's also hard to maintain. Yeah.
Yes.
Like sometimes you reach that point and you're like, oh my God, I did it. And then you go back into your regular routine. You're like, oh, I'm not doing it.
It's a continual journey of being mindful.
Yeah.
Yes, exactly. And no, like it's a skill just like riding a bike. You have to develop it and then practice it. But mindfulness is really kind of deliberately directing your attention. And that is a skill that in today's world with social media that we talked about earlier is really hard. So that's a cornerstone. Distress tolerance is really when we're feeling really more than 100% overwhelmed in those high intensity emotion times. What are some things that we can do in the moment? Cold temperature has been found to really be helpful, again, to address that physiological body response. So there's many skills under that umbrella. Emotion regulation is, again, when you're in a calmer but still kind of distressed state, what are some things that you can do to take care of yourself, to feel less intensely emotional in a way that you don't want or is not congruent with the situation? That includes skills like the thought records that we talked about earlier. And then the last cornerstone is interpersonal effectiveness, which is actually probably my favorite because this one is really about offering some skills that teach us how to get what we want that's consistent with our, in a way that's consistent with our values and in a way that reinforces the behavior for other people so that kind of other people want to do things that we are asking of them.
Manipulation. I'm just kidding.
We try not to say that in our field, but it's really, I think it's really good. I think DBT is really good, and I think that everybody could benefit. And there are some studies that are actually trying to teach DBT to children because essentially we're not taught these skills ever, and most of us.
And we're shoving them into an iPad. So.
Exactly. So if we can do that at a younger age, I think everybody could benefit.
Yeah.
This podcast is proudly sponsored by Vizzy Hard Seltzer. And with Vizzy's vibrant flavors, you can now follow your own vibe.
For those of you who know Queer Collective, you know that Vizzy has been a longtime supporter of us and our mission to create accurate and positive representation for the entire queer community. So if you are a hard seltzer drinker, we highly recommend drinking and supporting one that you know also supports the queer community.
And now, back to the episode. I think therapy itself can be a lifelong journey. I don't think you ever really stop or need to stop or necessarily want to stop unless you run out of benefits. And I did, I think, a lot of talk therapy when I was younger. And lately, I've been exploring IFS therapy, which is internal family systems therapy. All of them have been extremely helpful for me. I think that when I was younger, I think like early 20s, that was the first time that I've ever received therapy ever in my life. So for me, as like a 20-year-old, having freshly just come out to my family and dealing with all of the internal and external struggles of that, especially being from an immigrant family and like the cultural struggles of that, like so many different things. Getting talk therapy for the first time ever was such a great way to feel like I wasn't alone. So I think any therapy, as long as like you vibe with your therapist, is probably going to be a little bit helpful. Recently, I've been trying to kind of like deconstruct where all of my deep-rooted trauma or reactions to trauma come from, and why it comes from the place that it comes from. And I think that diving deeper and exploring different types of therapies, like you were mentioning CBT, DBT, or even IFS, all the 3-letter acronyms that we can think of, can really help you dig deeper into not just how you currently feel, but also why you feel that way, where it comes from, how to deconstruct that. At what age did you start feeling that way? Like that's something that I'm like exploring with IFS therapy. And it really helps me dial in on how I even developed either that trauma response or how I developed shame or how it's followed me in a way that I thought that I had like kind of gotten rid of. Being able to retrace back to sort of where it all began has really helped me not just deconstruct how I got here, but also start to heal and have compassion for how I got here. Because I think that I can be very hard on myself, and I'm sure I'm not the only one. And I think that the more that you know about yourself, the better you can help yourself.
I think I've had similar experiences in therapy too, where it's like like I said, such high levels of anxiety, but it's like figuring out what the actual root of this emotion is has always helped me. And you can also do that through like journaling too. I think like I had access to therapy in university, and then I've also, of course, we don't have great insurance now, but so
it always comes down to coverage, doesn't it?
So I mean, like journaling and finding the root yourself can also be an option. Like you said, there's worksheets that you can access for free.
Based on what you both just said, I also, there are ways outside of therapy. Therapy is just one modality, right? It's just the modality that I know kind of the best because of my training. But I think that journaling is such a good idea. And that made me think of other ways of expression. I know that many folks I know have benefited from, whether that be dance or art therapy. It could be art therapy, but it could just be art. Expressing yourself through music. There are many ways through creativity that you can kind of express yourself and process your life and your experiences as well. So therapy is not the only option, but it can be helpful.
Definitely.
Yeah, absolutely. And just to attest to that, I'm also a dancer, and I've been dedicating myself to dance like really intensely for like the past year and a half. And there has been some moments in the past year and a half that have been really, really hard. And I was like, shit, I got dance rehearsals. And then I go in and I'm so low and like just beaten down and like so sad. And then after all of the dance rehearsals are done, every single time that I've gone in feeling low, I come out feeling way better. I think that art and expression and movement itself as well really helps you get out, like physically get out all of these emotions that you're feeling, and really helps you like reset yourself. I'm actually on a dance break right now. I'm on like about a 2-month-ish dance break. And the time that I have that isn't taken up by dance, I'm like, I realize I need something to do. So I've been doing like home upgrades and renovations and stuff like that. I'm like, I need to move.
You need an outlet.
Somehow. I need an outlet. And like, I didn't realize how big of an outlet it was until I stopped. And now I'm like, oh, what do I do with my hands? What do I do with my body? So, yeah.
I want to just jump in there as well and just add that I could not agree more. And I love that you shared that. I wanted to add that the body-mind connection is huge, as you mentioned. And we often don't think about that, especially in traditional mental health care. It's very kind of therapy is mostly sitting and talking, which is, again, great. Not knocking that in any way.
Yeah.
And I think there's space for recognizing that body-mind connection. So, for example, I've been doing Pilates for the last 2 years, and I've done yoga before that. And I have found that movement, intentional movement, being aware of my body has changed my life, not just my physical, but also my mental health. I think that trauma, it doesn't have to be big T trauma, little T trauma. If it's not processed, or even if it is processed, it can get held in the body. And so sometimes therapy can help unlock that. A lot of therapy nowadays actually incorporates a lot of somatic work, body work. Outside of that, you can also engage in other types of movement-based work or creativity that can also help.
We spoke about not being able to afford therapy, and I know you working with CAMH. Is there any way that people can access free therapy?
It is difficult. I think most programs are time-based or time-limited, unfortunately. That doesn't mean that it doesn't exist. In Toronto, we are a little bit fortunate because there are a lot of community organizations, LGBT, 2S LGBTQIA plus community organizations that offer low cost or free counseling or mental health resources, Friends of Ruby or the 519 or Sherborne Health, amongst others. There are also such community-based organizations in other cities across Ontario as well, but it becomes more and more infrequent, especially if we get more rural and remote, unfortunately.
Yeah.
Some of these organizations will offer virtual access to support. For example, PFLAG Toronto has a virtual group for trans feminine people that I believe is still virtual. And so there are many options that are virtual, so you can access it wherever you are in Ontario or even outside of Ontario. If you need more kind of specialized mental health care or psychiatric care, I would encourage you to start by going to your primary care provider if you feel safe and comfortable. They are often the first point of contact. If you're struggling with more clinical depression or other sort of clinical more psychiatric issues. And then they can refer you to a psychiatrist if necessary. People like me, psychiatrists, we build a government. So, with your health card, you can access care, but oftentimes we're not able to offer formal therapy per se, more medication management, time-limited support. But depending on where the primary care person is located, I know that many family health clinics, community health organizations, community health centers, they actually have access to therapists, social workers, and they can do short-term or even longer-term work. So sometimes the first step is to find a primary care provider, which is hard on its own. We won't go into that for now. But if you are able to, sometimes that primary care provider is connected to therapy resources. So look into your kind of primary care sites. And then if you get referred for care such as at CAMH or sort of to a psychiatrist, sometimes they also have access to short-term therapy that they can refer you to. At CAMH, we have the Rainbow Services Program, which is this program in the addictions division where queer and trans people who are wanting to reduce or address their substance use, they can access a group and evidence-based supports for free with their health card. We'll talk about transition-related care in a second, but if you need some support around that, you can also get a referral from your primary care provider to the Gender Identity Clinic where I work. And we mostly focus on medical transition care support, but we also have some connection to other mental health supports as well. And then the last thing I wanted to say, if you feel like your primary care provider might be queerphobic or transphobic, which unfortunately can be the case, I've heard a lot of that from my clients as well, then of course I wouldn't necessarily recommend you go to them unless you feel comfortable. It's their job to help you. So even if they are queerphobic and transphobic, it's still their responsibility to direct you to the right sources of care. So if you feel comfortable, you can still talk to them. But if you don't, sometimes leaning on community is kind of the best way to go. And whether that's like informal community like Reddit or, message boards to ask what kind of resources are in your local area, that are vetted and trusted by the community, or asking friends, chosen family, or asking community organizations in terms of what they might recommend. That can be helpful too.
This next section that we want to jump into is the role of psychiatry in medical transitions, like you were alluding to. And the first question I wanted to ask you is how you personally navigate the tension between providing medical transition support in the history of psychiatry's role in pathologizing queer identities.
I think that the first thing is to, again, acknowledge that history, that psychiatry has pathologized queer and trans identities. The DSM-3, which is the third iteration of the DSM, which is the Diagnostics and Statistics Manual. I think that's right. The DSM is what we use in North America, especially Canada and the US, to diagnose people with mental health conditions.
Yeah.
And the third version of that included homosexuality as a psychiatric diagnosis or disorder. That has since been taken out of the DSM, but that history exists. Now we're on the fifth version, so the DSM-5, and that version includes a diagnosis called gender dysphoria, and that is really talking about recognizing the distress that people who are trans or gender diverse experience because of a mismatch between their experienced or lived gender and their assigned gender or assigned sex at birth. And so that diagnosis for many folks feel pathologizing, and I don't disagree with that. I think in order to challenge that pathologizing lens, the clinicians at our clinic really try to frame this diagnosis more as an access key as opposed to measuring whether you are trans enough, because that's what the diagnosis has been used for against trans people many, many times by clinicians. And so understandably, trans people are really mistrusting sometimes of healthcare systems to care for them. Whenever I do teaching with clinicians, I try to encourage them to really frame the gender dysphoria diagnosis as an access key to unlock access or facilitate access to gender-affirming care that they need and that they deserve.
I think to give people a definition as well, to pathologize is to view or characterize someone or something as medically or psychologically abnormal. And this is a lot of what we'll hear of like electroshock therapy and like forced into institutionalization, aversion therapy, these kinds of things that would happen to the gay, lesbian community. But this was also happening to the trans community too, when it was originally put into the journal, like you were saying, as a gender identity disorder. And then in 2013, which is fairly recent, was switched to gender dysphoria, kind of shifting the focus from pathology to distress caused by societal incongruence, but was only also changed by the World Health Organization in 2019. Which again, very recent.
Just to add to the World Health Organization, they have a separate diagnostic manual called the ICD, and it's on its 11th version, ICD-11. And they did something that I think I actually really applaud, which is they don't use pathologizing language anymore. They instead of gender dysphoria, they call it gender incongruence, which is just a mismatch between a person's outside and inside, essentially, related to their gender identity. And they also moved gender incongruence as a diagnosis out of the mental health chapter and into the sexual health chapter. How we in Ontario facilitate access to medical transition for folks is based on an international set of guidelines called the WPATH guidelines, which is the World Professional Association for Transgender Health. So this is based on expert consensus and research evidence, and they have a standards of care. It's in its 8th version now, but Ontario currently is still using the 7th version. So that's what I might encourage the government to consider is, if possible, to move to be aligned more with the latest evidence, which is the 8th version of the standards of care. The new standards of care also advocates for the use of gender incongruence as opposed to gender dysphoria. So if that's another way that if the government could align their policies for funding around the latest standards of care, that could be more depathologizing and be more aligned with the international standards.
Do you find the word dysphoria, like gender dysphoria, to be a bad word? I do feel like a lot of people in the community use it. I think researching for this episode was the first time I started to see people feeling negatively towards it. And it may just be because like the APA used it and there's like a dark history with the APA. But it's like you do hear a lot of people in the community just casually using dysphoria and euphoria, like it doesn't feel necessarily to me as pathologizing, but I know you're in the field. So what do you think?
The first part of my response is I think if folks find gender dysphoria as a diagnosis pathologizing, we have to listen to them and really reflect on that as a system. However,
I guess I'm like, do we find it pathologizing?
Yes.
Or is it, I guess, it being a diagnosis is pathologizing?
That's exactly what I was going to say.
Right.
I think that my understanding is that it's the fact that it's a psychiatric diagnosis that makes it pathologizing. I think that, like you said, a lot of trans and gender diverse non-binary folks I work with, they use the word dysphoria all the time.
Yeah.
They say I have chest dysphoria or face dysphoria or what have you, or voice dysphoria.
Yeah.
So you're right. A lot of folks will use the term dysphoria. I think the pathologizing part is the gender dysphoria as a psychiatric diagnosis. I'm a very pragmatic person. So at the end of the day, I don't care as much about the label.
Yeah.
I do think that psychiatry, through my training, has offered me a way to understand people. I don't always agree with it. In fact, there's a lot about the DSM that I disagree with. But it has allowed me to offer tools, interventions, ways to alleviate suffering.
Yeah.
And so that is what I focus on. I'm okay if the person who comes to me doesn't agree with psychosis as a language or major depressive disorder or the diagnostic manual, but do these clinical diagnoses offer a way for me to help the person in front of me to access some tools, some care, some supports that can help them feel better? Because at the end of the day, that's what I want to do, is alleviate suffering, because the person is coming to me for a reason. And if we disagree on the language we use, I'm more than okay with that.
Yeah. And I think part of this like bigger umbrella, what I've learned is there's like a full anti-psychiatry movement versus critical psychiatry, which I feel like based on the way that you're speaking throughout this whole interview, I feel like you are definitely critical of the field. And of course, like one seeks to like abolish the entire field, and then the other one believes that it can be repaired and that it also is a useful solution in tandem with other solutions. So I don't know. I thought it was an interesting thing to think about as well.
I think that a lot of folks who have been through the psychiatry system has felt harmed. And I think some of those folks especially feel very anti-psychiatry, which I totally understand. Psychiatry holds kind of dual roles. It holds many roles, but one of the roles is what we talked about, which is that we try to help people feel better if they have mental health distress or mental illness, if you use that language. We also have this role that society has given to us, which is where society has defined what is normal or normative.
Right.
And then if you are multiple standard deviations, meaning quite outside of that, if society has deemed you to be acting way outside of what they consider normative, then society has also asked psychiatry to, quote unquote, manage those people. It's about who has power to make those decisions and who doesn't. And oftentimes it's folks who are marginalized or oppressed, including queer, trans, racialized, people who are houseless, experiencing homelessness. Those folks have less power. And so the folks with more power get to define what is normative and then what is acceptable behavior, and then they get to police or monitor that behavior.
You mentioned earlier in the episode that especially, all of our advice has been for queer and trans folks so far. And we were talking about how a lot of the times situations that we're in because we're in marginalized groups are not our fault, because whether it be societal standards that were put on us or cultural things or family things, very situational a lot of the time. However, there are things within our control, and it's up to us whether or not we want to access that, implement that.
Yeah, and I will say for folks who are listening, I know it sounds cheesy, like the "it gets better" messaging. Like it is worth grabbing the hand and like taking the steps to get better. I think what's on the other side for you is a lot of joy, a lot of happiness, a lot of fulfillment that life can bring you, even though it can feel really dark right now.
Getting back on track, we were talking about medical transition and medical care, specifically for trans folks. And I'm wondering, what helps you determine if somebody is ready for a medical transition?
In Ontario, it goes back to those international guidelines that I was talking about earlier, the WPATH standards of care. So right now, the Ontario government is still using the version 7, the last version. So we follow that. So some of the criteria that they currently require include a diagnosis of gender dysphoria, which we've kind of talked a bit about. They have to have, quote unquote, stable, or actually the language is reasonably well-controlled or well-controlled mental and physical health, which can be challenging language, again, can be pathologizing language. But we try to operationalize that in a depathologized way.
Can I ask, how you would diagnose someone with gender dysphoria? Like, what does that even, how do you do that?
If we're strictly speaking, the gender dysphoria diagnosis in the DSM-5 has 6 criteria. Distress related to a mismatch, basically in terms of their physical appearance, their outside and their inside. Their outside is inconsistent with their lived gender or experienced gender. And then you have to have 2 of the following 6 criteria, and it has to last at least 6 months. The first one, I'm going to try to do this roughly. Don't quote me, you can look it up. But roughly, it's the first one is a person's primary and or secondary sex characteristics don't match their inner gender or their lived gender. Could be chest, genitals, voice, hair even, hair quality, skin texture, facial features. All of those are primary and or secondary sex characteristics. The second one is wanting to get rid of aspects of their primary and or secondary sex characteristics in order to match their gender. The third is kind of the converse of that, wanting a primary and or secondary sex characteristics that matches their gender. So breast augmentation or breast development, perhaps for some folks. The fourth criterion is basically wanting to be treated as the gender that they are. So, feeling a lot of distress when they're misgendered by other people. The fifth one is, I don't like the language because the fifth one is something about wanting to be that other gender. And I don't like that language because for me, the person is already that other gender. So I don't really use that criterion very much. I kind of intuit it based on the person saying the gender that they are, then they're already that gender. And then the sixth criterion is, inner feelings that are kind of congruent with the gender that you are. I don't like this one either because this one is based on a lot of gender stereotypes. It's kind of this idea that women are more in touch with their feelings.
Like binary roles and things like that.
They cry more. Men are stoic. So I don't like that. But those are the criteria.
I was going to ask you too, there's a lot of people who are non-binary who are looking to get same types of care. But aren't looking to go male to female or female to male, are just looking to feel more themselves or take away the dysphoria, but not necessarily go in a different direction into a new pre-assigned box, if that makes sense. Yeah. So is that how you're managing that? Or is it hard for people who are non-binary to navigate this system that's created?
Yes. Historically, it's been very difficult for non-binary people to get the care that they want. A lot of them have had to have binary care, because especially, 10, 20 plus years ago, even if they didn't want they didn't want hormones or they didn't want top and bottom surgery, they would have to kind of go through all of them. And also sequentially, starting with hormones, then top surgery, then bottom surgery, usually. So yes, historically, it has been very difficult. Now I think it is definitely better. It's not where I would like it to be, but it's better in a few ways. So the gender dysphoria diagnosis in the DSM-5, specifically the language is wanting changes to be congruent with another gender than the gender or sex you were assigned at birth. So it doesn't say, the other gender. It says an alternative gender or another gender. So it does recognize more explicitly non-binary identities. So that also then facilitates better access to care. Unfortunately, because we don't have a lot of good clinical training for physicians, for medical doctors like me especially, still don't have very good trans health training. If you are not trained, in a center like Toronto where we have more trans health expertise, there is still, I think, a pervasive view of gender as binary. And so if you have a doctor, outside of Toronto or the big cities, they may not understand non-binary transition trajectories. But now, at least at our clinic, we support many non-binary people.
I think the media likes to paint this picture that youth in particular are fast-tracked into medical transitioning without proper consideration. And I'm kind of wondering what you have to say to this notion.
What I would say is, I think, first of all, the caveat is I don't work with teenagers as much. I at our clinic, at the Gender Identity Clinic at CAMH, we see folks 17 and over. So they are still teenagers, but we don't see people who are younger than 17 currently. Fast tracking is certainly not my understanding of what's going on, especially not in Canada, where I practice. So first of all, I think it's important to clarify what people mean by youth, because youth has a broad definition and it kind of varies.
I still feel like a youth.
100%. Yeah. 100%. I'm not going to invalidate that.
Yeah. My insurance is still making me feel like a youth.
Yeah. I was going to say, I was still feeling like a youth until not too long ago.
Yeah.
Congratulations. Thank you. Yeah. Thank you. Actually, because some definitions of youth go up to age 29.
Yeah.
So, and actually, like for example, Friends of Ruby, which is a community organization that I talked about earlier, they offer services to youth, and they offer services up to age 29 for queer and trans young people. So just to clarify, a lot of the politicization when they talk about trans and gender diverse youth is really talking about teenagers. Yeah. And specifically, they're talking about adolescents or teenagers who are kind of in the early stages of puberty, because oftentimes they're quote unquote concern is around puberty blockers. Puberty blockers are a type of medication that kind of pauses puberty so that a young person who identifies as trans or gender diverse or non-binary, who feel like biological puberty is going to cause them a lot of distress. It allows them to take a pause, talk to professionals, talk to their loved ones if they want to, about their next steps. So that's kind of really how it's framed. But there's a lot of concern over this. They're saying, as you said, there's a lot of fast tracking. But my understanding, based on the research that I've looked at and knowing a lot of colleagues in the field, is it's the opposite. It's actually trans young people, adolescents, have a lot of difficulty accessing care, especially if you need to go to a subspecialized clinic. So in Toronto, we have the Sick Kids Hospital has a trans youth clinic. To go to that clinic, you have to presumably talk to your caregivers. Then you have to talk to your primary care provider, your family doctor, your pediatrician if you have one. Then you get them to refer you to the Sick Kids Trans Youth Clinic. Their wait time can fluctuate, but usually it's at least a few months. It can be a year plus sometimes, depending on how busy they are. And then you can go see them. But while you're waiting, puberty is happening, right, for some of these young people. And so that can be distressing, And then there is this perception that once you see a provider that they talk to you for 2 minutes and then they start you on a hormone blocker or they start you on hormones. And that is certainly not the case. To my knowledge, oftentimes there is an interdisciplinary team that does an assessment, that talks to caregivers if they want. Oftentimes caregivers are involved. Only after assessment, discussion, talking to the young person about risks and benefits as part of an informed consent discussion, only then are they facilitated access to transition-related care. And so certainly I don't think that it's fast tracking in my experience, quite the opposite.
This is given the notion that this person would have to come out to their parents to go and seek this care. As a child, you don't know how to go and start your own medical transition all by yourself. Like that just isn't. And I think that's part of the fear mongering is everyone's like, it's going to spread to my kids. They're going to go and do this to my kids. It's like, no, unfortunately, you're still in charge of your kid.
Even working with adults who live under the same roof as their parents or their family, I often talk to them very candidly and transparently about safety in the home. You know, if you are starting hormone therapy, you know, there might be changes. There will be changes. That's the goal. That's the hope, right?
Yeah.
So the people you live with may notice that. So especially if you're a teenager, you're dependent upon those people for financial stability, housing stability. You know, the best case scenario is to get them on board because if there's a lot of antagonism within the home, the thing I worry about most is that person's safety. Providers will always talk to the young person about how do we do this in a way that maintains your safety as well.
Yeah. And I think that's something important to remember is like this is not a decision that these kids are taking lightly, especially if you don't have an accepting household. It's one of like the biggest decisions of your life. It's something that you're having to weigh a lot of pros and cons. And like you said, medical professionals are helping them do that.
And I know you know this, but just for listeners and other people who might be listening, but the truth is transition or gender affirming care even is about so much more than medical transition. And so especially for children, people who haven't started puberty yet, there is no medical transition that's happening. There is certainly no surgery, not even hormone blockers, because that only happens, that only can happen when puberty has begun. So for children, even for teenagers, a lot of it is about social transition, affirming who they are, and it often has little or nothing to do with medical transition. So just to remember that, I think.
Yeah. And we did a whole episode, a non-binary episode, where we really talk about ways to transition that aren't medical. And there are so many ways to affirm your identity and work through dysphoria in a way that doesn't involve medical intervention.
In terms of regret and detransitioning, I feel like that's often used as a talking point for this big debate over whether or not this type of care should be available to people. I'm wondering if you have insight on what the research tells us.
I think, again, this is like a both and situation. It's like a very dialectic day to day. Regret and detransition do happen. However, they, as far as we understand based on the literature, it's a minority experience, meaning, you know, not the majority of people who start transition will regret or will detransition. That being said, this is a very new field. So there's actually not a lot of literature or research around it currently. I'm part of a study that is being led by Dr. Kinnan McKinnon at York University. He's done quite a bit of research on detransition. Right now, he is doing a mixed method study, which is like a quantitative study and a qualitative study, where we started with a survey, and we actually got, I think if I remember the number correctly, 959 respondents who have had some experience of stopping or reversing their initial transition. And we're undergoing the qualitative part where we took some of those, or we asked some of those participants to undergo an in-depth qualitative interview to really get a good sense of their lived experience. So the research is ongoing, but what we know so far is that detransition, which doesn't have a clear definition, but we're sort of defining it as stopping or reversing an initial gender transition, usually with a shift in that person's identity in some way, whether that's their gender or sexual identity. And this, by the way, includes people who shifted from a binary identity, which we talked about earlier, to a non-binary identity, where they maybe had certain medical interventions that they didn't need or want, but that's more because of not realizing perhaps that their non-binary was an option for them, and also the healthcare system being very binary, as we talked about earlier. So it includes those folks, but what we're learning so far is that detransition, as we're defining it, is actually a very heterogeneous concept, meaning like there's a group that has a lot of different reasons that they detransitioned. And the other thing I would say is detransition is different than regret. So some people who detransition actually don't have regrets. They don't regret their choices. For some people have told us that they, even though they're detransitioned, they are grateful for their initial transition because it helped them explore their gender in a way that they needed or wanted.
Make an informed decision.
Exactly. And some people need to do it to feel that way, right? Yeah. So exactly. So not everybody does, but some people do. And then but it's again a minority experience. And of the people who do, some of them may want what some people call reversal procedures. Yeah. So if they had top surgery to remove their chest tissue, they may want breast augmentation surgery or to reverse genital surgeries.
Yeah. Out of like the however many participants you had, do you know how many wanted that?
Great question. Not at the top of my head. I think it's a very small number, but look into our future research. Yeah. But still valid. And those folks have a lot of distress from my clinical experience as well. Not a lot of people have needed or wanted to detransition, but some have, right? I've seen hundreds, I think maybe even 1,000 plus trans and gender diverse clients over the last few years. And I can count the number on my hand, the number of people who have wanted or needed to detransition. Now, not everybody will come back to see me because they may not feel that I am the right provider or a safer provider to help them in their detransition. So that's just, an anecdotal number. But of the people who did want to detransition, I can think of a couple of folks who are in a lot of distress because you can imagine like they went through an initial transition, especially if they, had hormones. So they had for folks who are assigned female at birth, maybe they had their voice change or they've had surgeries, including genital surgeries. And now, they face fertility challenges or they face a lot of distress because they want to live as their assigned sex at birth, but they can't because they've had these procedures that have made it really, really difficult. Their body shape needs to change, aspects of their body. In a lot of ways, it's the same kind of distress that folks who are trans or gender diverse who undergo an initial transition, they talk about, right? But now it's kind of reversed. And so actually there's a term that folks in the community have coined called reversal dysphoria because it feels very similar to that initial gender-related dysphoria, but in reverse. And so those folks deserve and need support and care, even though it's a minority experience. And so part of our work is in hopes of figuring out what their care needs are in order to better support them.
It is challenging feeling dysphoria in both, like having experienced like both physical forms and still feeling dysphoria. It's where do you go next is probably can be a bit frustrating. I don't know if that also lends to what you're saying, that some people just don't know that non-binary exists and that like you don't have to be in either rigid box. It's like perhaps that may be the answer there.
Yes.
I don't know.
Yes, it totally is for some people. For some people, it's about shifting to be more comfortable in a non-binary identity.
Yeah.
For some people, though, they realign kind of with their assigned sex at birth. They'll say, but they'll sort of use maybe gender non-conforming.
Overall, it definitely is a very stressful experience. I think the hard thing is I don't want to minimize how big of a decision it is to change your physical body and have medical interventions like that. But I'm wondering, does denying or delaying gender-affirming care for trans youth impact their mental health and well-being in the long term? And it's kind of is weighing these two things of like making this really big decisions, but also the impact down the line of delaying it.
Yes, the two principles are intention.
Yeah.
Again, it's another dialectic. Again, talking about mostly trans teenagers, can be in a lot of distress because their body doesn't match who they are on the inside. And there are understandable concerns around sort of long-term impacts of making changes to a young person's body, especially around fertility, for example. I think that's what some of the research now is hoping to try to tease apart in terms of, are there predictors of regret? Are there Are there predictors of detransition? Not that detransition is always a negative outcome, as we talked about earlier. For some people, detransition is just part of their gender journey. But more of that research can help that informed consent discussion when a young person is making that decision with their healthcare professionals and their loved ones, their chosen family or their family of origin. Ultimately, I think that I'm not for policies, because I think this is really what the question is about, right? It's really about whether policies from governments should consider, banning or restricting certain types of care for adolescents. And I am not in favor of that because I don't think a one-size-fits-all solution works for anybody, And so I think these considerations are important. But I would say, why are we not leaving these decisions to the young person who knows themselves best, along with the loved ones that they choose around them, along with their healthcare professionals who have had many years of training to do what they want, who the last thing they want is to harm this young person, right? There are some young people who may, quote unquote, regret, not quote unquote, they may regret their decision. They may be harmed by the process. I'm not invalidating that at all. But the research suggests that, first of all, this is a minority experience, as I've said many times, but just to really be clear around that. And the way to minimize regret and detransition is not to restrict access entirely, but to be more nuanced and have a really individualized approach to the young person in front of us.
With anything ever that has existed, some people will benefit from it, some people won't. And there's always going to be cases where either somebody regrets it or somebody, needs to detransition or it didn't go the way that they had hoped. To stop something isn't necessarily always the answer, but rather to have more information on something typically is the answer.
100%. I was going to say, it seems like more research is needed rather than like a hammer fist rule coming down before you have all of the research. But I can see for parents, it would be a difficult thing to navigate when you don't have a full spectrum of information available to you. Yes. And it's such complicated, difficult emotions too, when you want the best for them and you're trying to find all of this information the best that you can.
And to navigate what is best, what does best mean, in the short term, in the medium term, in the long term. We talk about regrets for other medical procedures. Generally speaking, as far as we know in the research, regret rates for gender-affirming surgery are much lower than, say, elective plastic surgery, for example. Regret is usually less prevalent compared to knee replacement surgeries, hip replacement surgeries. Society, not individuals specifically, but broadly, don't believe that these surgeries and these interventions are medically necessary. And therefore, they make the case that even a 1% or even, a low percentage of regret is unacceptable. No choice is perfect. People regret tattoos as well, right?
So many people regret tattoos.
And again, I understand. I'm not trying to trivialize that this is perhaps more invasive than tattoos, depending on what it is, right? I think part of the discussion that often is missing is that the reason we kind of say, well, we should just ban this care for certain age groups is because these people, these governmental folks, don't believe that it is medically necessary.
Right.
And I don't think they're listening to these individuals who are experiencing this deep level of trauma and day-to-day agony, truly, that is going through life not feeling like you're in the right body. There's so many ways that we organize our society. I feel like this has been a big part of our discussion is the government and the majority of people making decisions that they think are best for a group of people that they honestly know very little about. And I think that is how so many bad laws end up happening, really, is when we're not allowing someone to be the agency of their own experience and not allowing them to make decisions that are best for them.
Even when people make the decisions that aren't best for them, at the end of the day, it is their decision to make.
It's their body.
And it's their body. Yeah. And like you said, people regret tattoos, people regret plastic surgeries, people regret medical surgeries as well. And just because that is the case for some people doesn't mean that these things shouldn't exist.
Yeah.
And that people shouldn't have agency over what decisions they make with their body as well. Thank you so much for joining us today, June. And thank you for answering all of our questions. I know that we really gave you a lot. So we really do appreciate all of your input today.
It's such my pleasure. As I said earlier, I could talk to you both for hours, so maybe we will off camera.
So that's everything that we have for you today. And if you want to dive deeper into the non-binary experience, we have an episode on that. It's called What Does It Mean to Be Non-Binary? Make sure that you hit subscribe. And if you're on your favorite podcast app, make sure to leave us a 5-star review because it really does help the podcast out. That's everything that we got. And until next time, peace.